The second way that I think that the legislation really transforms medical practice is how it structures health insurance in these exchanges. So Jenna talked about the fact that in 2014, really the crux of the bill goes into effect. Every state has to, states that comply with the law, have to start exchanges where insurance is going to be sold in basically a state-based marketplace, and consumers will have the option to go into that marketplace and purchase insurance. And depending on your income level, you might get a government subsidy to buy insurance in that marketplace. The big question in Washington is how many people will actually end up in those state-based exchanges. Most people concede, both Democrats and Republicans concede, that the individual market, basically going on the web right now and buying insurance from a health insurer, all that will move into the exchange immediately. So you're going to eHealth.com and buying insurance on your own, that'll move into the exchange. Most people think most of the small group market will also move into the exchange. The small businesses that buy insurance on their own, most of them will put their employees into the exchange. The big question is how many of the large group plans, how many of the big employers who currently provide coverage will put their employees into the exchange? I think most will. Basically, an employer will, if an employer or a large employer doesn't provide employer-provided coverage, they have to pay a $2,000 penalty per person who goes into the exchange. But the reality is if you're a large employer and you have a lot of low to middle wage employees, it's simply going to be a better economic deal for you as the employer and frankly for the employee to go into the exchange. And I can go through some of the numbers later in terms of why I think that. But I do believe that a lot of the action, a lot of the health insurance market will move into these federally regulated, federally managed, but state-based exchanges. So if you accept that thesis, the question then becomes, what does the insurance look like in the exchanges? And for a lot of reasons, I think the insurance is going to be a pretty skimpy insurance product. It's not going to be Medicaid managed care. It's going to be better than that, but it's certainly not going to be the average employer-provided plan. The actuarial value of that coverage is set at about $14,500. Right now, the average plan sold in the private market has an actuarial value of about $15,500. This is for a family of 4. So right off the bat, it's a cheaper insurance product. But most of the coverage that we get in the private market, we have a lot of copays, we have a lot of deductibles, and that they use that to try to drive down the cost of the coverage. The coverage sold in the exchanges, the amount of copays and deductibles is going to be heavily regulated. There's a lot of first dollar coverage of primary care. I think that's going to be made up on the back end by trying to control utilization on the things that are expensive. So if you take a cheap insurance product and then you force it to have to cover a lot of routine stuff that normally an insurance product wouldn't pay for, it's got to be made up somewhere. There's no free lunch. And I think it's going to be made up on the back end on the more costly things by trying to get tighter control on utilization. So then the question becomes, how do you get tight control on medical utilization? There's really only 2 ways to do it. Either you offer a very narrow network health plan, where you offer health plans that don't contract with a lot of people, a lot of doctors, so you can tightly control the doctors, or you own the doctors. You just buy the doctors and they can work for you. And that's exactly what's happening in the marketplace. If you see the types of health plans that are being designed right now, they're either narrow network plans, or when you see what the health plans are doing, the big insurers, they're going out and trying to buy up providers very aggressively. They're actually bidding against hospitals to buy up doctors. And that's because they know under this new plan, they're going to have to get very tight control of utilization to try to control costs, to try to come in at that very low actuarial value that the insurance is pegged at. So it's another way that I think that you're going to see more control on utilization, doctors consolidated into large networks where they basically become employees of systems. The whole idea of Marcus Welby practicing as a doc in a box somewhere, that doesn't exist anymore. Upwards of 70% of all physicians now are either employees of hospitals or hospital-owned health systems or health plans. And the trajectory in that's growing very rapidly. You know, the percentage of physicians who are independent working for small groups is going to be probably 20% at most, maybe in 3 or 4 years. The consolidation is very quick right now in the marketplace. So that's because you're going to need, under this new scheme, to try to bring down the actuarial value of that insurance product, you're going to need to control the physicians more directly and what they can and can't do. And that's how we're seeing the marketplace evolve. Finally, you know, the final thing that I would just say in terms of how this changes the relationship to the practice of medicine is just that we're going to see more federal regulation of the practice of medicine. When you look at, historically, healthcare legislation, major healthcare legislation over the last 40 years, the legislation always stipulated that the regulation of the practice of medicine wasn't subject to the federal government. It was always left to states to regulate the practice of medicine, the practice of pharmacy. And you can look back at the original Medicare legislation, you look back at the medical device statutes that created the modern infrastructure for regulating medical devices. You look back at some of the FDA laws that were passed in the 80s and 90s, and Congress always inserted into those laws statements that it wasn't the federal government's role to regulate the practice of medicine. That's not true anymore. I think most in Washington now believe that it is the government's role to regulate the practice of medicine, certainly inside the federal agencies and frankly inside this administration. And we're seeing more constructs created that will regulate aspects of the practice of medicine, and a lot of them are embedded in the Affordable Care Act in the legislation that just passed. So many of you probably heard of IPAB, the Independent Payment Advisory Board, which is basically put in place. The mission of this board is to cap the rate of growth of Medicare. So what they said in the Affordable Care Act was that Medicare's rate of growth couldn't grow by more than GDP plus 2%. And the president has since revised that in his most recent budget, saying that it can't grow by more than GDP plus 0.5%. So they've effectively capped the rate of growth in Medicare. So interestingly, both the Romney healthcare plan and the Obama healthcare plan both put Medicare on a budget. When the president says that Romney cuts Medicare, really what they're doing under the governor's plan is putting Medicare on a budget and giving people the money to go out and buy insurance with a stipend equal to that budget, if you will. What the president does is he also puts Medicare on a budget. He caps it at the growth of GDP plus 5%. And what they do is they say that IPAB's mission will be to make cuts in reimbursement to providers to stay under that cap. So if Medicare is projected to grow by more than GDP plus 0.5% now, IPAB's mission is to basically cut the reimbursement rates to providers, to hospitals, to nursing homes, to whoever, to try to bring down the rate of growth of Medicare. When you cut reimbursement rates, inevitably you forestall access. We've seen that under Medicaid. Medicaid's reimbursement rates have been sanded down to such low levels that Medicaid recipients have a very hard time getting access to care. But that's what IPAB does. Now I think IPAB's going to do that, but it's going to do something else. It's basically a board of about 15 people who are appointed for 6-year terms. They're not going to be able to get into sort of granular considerations of we should take this rate down and move this rate up. So they're going to burn down existing price schedules that already exist in Medicare. They're going to import price schedules that exist in one aspect of the marketplace into new aspects of the marketplaces. And third, they're going to confer CMS, Medicare and Medicaid, where I used to work, with new authorities. And this is the part that I wanted to get to. Because what they're likely to do, and what Medicare and Medicaid, the agency that administers Medicare, has long wanted, is the authority to become a clinical arbiter, to make decisions in Washington about what the relative value of different treatments are and what they should and shouldn't be paying for. They've long wanted those authorities. They don't have them now. They've tried to seek them out. They've actually gone to court to try to get them. Lost a lot of court cases, a lot of federal court cases, when judges struck down things they tried to do. But IPAB can effectively confer those authorities onto CMS very easily, overnight. And I think that that's what IPAB's most likely to do. So it's another way of giving a federal agency, if you will, authority to regulate, to directly regulate aspects of the practice of medicine. And I think that that's the third way that the bill really remakes medicine in this country. Every major piece of legislation is always sort of a pivotal moment, a memorable moment that I think defines the legislation. And there were two memorable moments with this bill when this bill was passing, or was moving through. The first was an article written by a New Yorker columnist by the name of Atul Gawande, a surgeon, where he looked at the practice of medicine in a Texas town and compared it to other parts of the country, and identified very wide variation in terms of what doctors did in this small town, not so small town, but this town in Texas, versus what doctors did in other parts of the country. And the conclusion was that there was a lot of variation in clinical care. The practice of medicine was more costly in this town, and that must mean that there's a lot of waste. That the variation in and of itself, if doctors in one part of the country are doing something different than doctors in another part of the country, that variation in and of itself means that someone's doing something wrong and it's wasteful. Someone's not reading the right medical journals. The president really seized on this and used it as a big impetus for aspects of the bill, and said that a lot of the savings that he would be able to achieve was by putting in place mechanisms that would sand away this practice variation and bring everyone to the same standard, the same medical practice, if you will. So they put in place things like the PPACA and other entities in Washington to try to create standards of care that they would promulgate from Washington. And the other defining moment was during the ABC News town hall that they had in the White House. I was there in the audience. They put all the conservatives underneath these big lights. We were worried the whole night that the lights would fall on us right at the point that the president was taking away our health insurance. But he talked about a lot of things that night, and one of them really struck people. A woman got up and talked about her 90-something-year-old mother who had just gotten a pacemaker. And the president questioned whether it made fiscal sense to put a pacemaker in someone who was so old. And there was sort of a hum in the audience because I don't think he meant to be callous, but it certainly encapsulated, I think, a lot of what people were fearful about the legislation, that these kinds of considerations would start to be made in Washington. I'll just close that. I think that the sort of defining vision inside the White House by Peter Orszag, by thoughtful people who worked on this legislation, was a view that medical practice in this country, there is wide variation in medical practice, that doctors are incentivized to do more because of the fee-for-service payment system, and that the way to bring down healthcare spending wasn't to try to move healthcare towards a more market-based system where there was competition that tried to drive down costs, but by putting in place mechanisms that tried to sand away this practice variation, that by trying to get everyone towards a more uniform standard of medical practice, we could not only improve outcomes, but could bring down costs by bringing down the high-cost providers to a sort of moderated standard of medical practice, if you will. That really is a defining vision in the bill. You've heard it articulated many times, and I think it's embodied in a lot of the proposals or the aspects of the legislation I've talked about here tonight.
Thanks, Scott.